Thank you to all who are joining us today for our Preverity update on what we're seeing in healthcare data. I'm Larry Van Horn. I'm a professor at Vanderbilt University and CEO of Preverity. And hopefully this is an update to information we provided a number of weeks ago with our friends at MPL. And we had a great experience with Divya and those folks. And we are going to give you a little bit more color into what we're seeing in the data since that point in time, and address some questions that people were kind enough to send in to us. And that's the agenda for today. I have to do my standard disclaimer, which is everything I'm saying in no way, shape, or form represents or reflects the opinion of any organization that has the unfortunate position to be affiliated with me in some way, shape, or form. And that includes my dear employer, Vanderbilt University, and organizations I'm affiliated with. This is just Larry having a conversation with you about what I'm seeing in the data, powered by my friends here at Preverity. I want to thank Spencer Jones, head of machine learning at Preverity, and Rachel Hayes, the chief data scientist, for putting together a bunch of this information that I'm going to go through with you all today. So that's our goal here is to go through the volume shifts that we see in the data and the return of volume, and some forecasts in terms of when by various markets we'll return to peak volume. We've had a number of questions about telehealth, so I'm going to spend a fair amount of time unpacking and talking about telehealth in particular. We'll talk about a little look at some prescribing behavior and changes in prescribing around the start of the COVID-19 outbreak. And then I'll show you a few risk factors. Some folks had asked questions about senior liability and whatnot, and I'll have some thoughts on that as well. So just to reorient and refresh, we have two primary data assets here at Preverity. One is our real-time data asset infrastructure. This is a limited data set. It's highly aggregated, but it gives us a very real-time signal as to what was going on in the last week. And I'll show you data all the way up through Friday of last week. We have a much more robust data structure. That's our enterprise data warehouse, where it's 2 months lag. And given now that we're 2 months removed from the start of COVID in March, I've been able to leverage a little bit of what we see in our enterprise data warehouse in the month of March to unpack and give you more granularity in terms of the changes in practice behavior in the United States. So these are the assets we're using. But I think one of the big questions, and one of the most noteworthy things here, is the change in volume in America. And so this slide here reflects prior to March 15th, prior to March 15th here, and that's when the world changed in US healthcare. And you can see in this slide here, the orange is office visit volume nationwide, the red is hospital outpatient, and the blue is ED volumes. And you'll see that office visit, the green, actually came down and cratered right down here at around 40% in the first week of April. All right, and it started rebounding by the third week of April, right around in here. It started going back up, and now it's come back up to, well, almost it's come up about 30% from where it was at its trough. So if you just take that math over this 6-week time frame, we basically recovered 30% of what was lost. So if you extrapolate that, it would suggest that by the time we hit the end of July, office visit volumes should return to where they were pre-COVID levels, notwithstanding the economic changes that have occurred in the United States, and I'll add color on that as well. So I think in terms of forecasting, this is a pretty straight trajectory that you see these graphs on in terms of office visit and hospital outpatient activity. And that activity suggests that while we get to the end of July, we'll probably start seeing us move back to our pre-COVID levels. All right. Oops. There, we'll move there. This is not too dissimilar from individual foot traffic patterns as measured by Safegraph. And so Safegraph measures point of service and foot traffic by types of organizations and by industry sector. And you can see that they all dropped on March 15th, and there's been this gradual return. Interesting enough, hospitals, their number for hospital activity pretty much comports with what we see in our data as well. But it's been pretty flat with a little bit of an upward trend. Counter service restaurants starting to come back, general merchandise stores starting to come back. But I don't think anybody's going to movie theaters right now. Let me see if I can get.
I think it's on the other end.
Oh, there we go. Now, the nationwide drop in the return, we started to unpack that a little bit, and we started to look at it by the size of the population density of markets. And so what you'll see here, what you see here is on the top left, these are densely populated urban markets with populations greater than 1 million individuals. And on the bottom right, you'll see small counties with low population size, so less than 100,000. And while in the urban markets, you saw this drop that dropped, it troughed around, almost a 70% drop peak to trough in terms of the office visit and hospital outpatient activity. In the more rural markets, that drop was not nearly as great, and the trend of return to volume is returning faster than it was in terms of compared to the densely populated areas. So we're back at around 75% of pre-COVID volumes in terms. Sorry, there we go. In terms of pre-COVID volumes, whereas in the urban areas, we're probably still about 10 percentage points down in terms of their population, kind of the density, the return of volume in those densely populated areas. We can look at this by state as well. We highlighted here a number of states in which there was noted activity, COVID activity. So I have New York in the top left panel, Louisiana top right, Michigan lower left, and Massachusetts lower right. And if you look here, you'll see a number of things that I think are kind of interesting. First, going to the, if you look at Michigan, Michigan had the biggest volume loss of any of the states, dropping, almost losing 70% of the volume. Whereas if you look at Louisiana, they dropped, much less, losing probably 50% of the volume. And what's also noteworthy here is that Louisiana's had a much faster rebound in terms of their activity than you had in Massachusetts, for example, where you got this very flat, slow return of outpatient clinical activity. And so while we can say that by the end of July is when overall you would see volumes return, it's going to be much more nuanced than that. And in Massachusetts, I think it's going to take a lot longer for those volumes to return than they would if you were in, say, Louisiana. And these were the harder hit areas. If I go and look at instead some other states, Oregon, Montana, Utah, Wyoming, more rural states, there was a much more consistent return of volume, and they didn't lose nearly as much volume as, Utah only lost, 25, 30% of their volume compared to Michigan, which lost 70% of their volume. So it's a nuanced conversation by state. We can also unpack this and look at it within counties within the state. So we took a look at New York State here, and I spent a lot of time in upstate New York and Rochester, New York. And in Rochester, which is Monroe County in the top right, you see that the volumes there dropped and they came back quite quickly. Whereas in New York City, in the bottom right panel, you can see the volumes had a more significant drop, and in particular, it didn't return nearly as quickly. Take a look at Albany in the top right. Albany didn't experience nearly the drop, and the volumes returned quite rapidly in Albany. So, we've got probably 1 month of time left, and volumes will have returned back to pre-COVID levels in Albany. So if you remember when we were together last, I showed you some slides here looking at how much volume was lost. Last time we were together, on 5/13, I showed you the figure on the left. The lighter the color, the more volume was lost. The darker the color, if it gets to be dark red, if the volumes return. And you can see that across the country, generally speaking, volume is returning in terms of office visit activity as of last week. In the ER, again, the volumes are starting to come back nationwide. There are some areas that are clearly noteworthy. The north central part of the country, you have much more volume return. But in general, right across the country, we see the volume starting to come back in terms of ED visit activity. And finally, hospital outpatient is more mixed. It's not as consistent. We certainly have areas that are still quite down. So California, for example, Iowa, New York State, their hospital outpatient volumes still are quite depressed. Now, volume is one measure. The second measure that's important is the intensity of care. So we went and we looked at the RVUs, the work RVUs by specialty across the country, and came up with a metric to assess how much the intensity has changed. So what this figure here is showing you by specialty, the decline in the number of work RVUs by specialty. And it's reasonably consistent, somewhere around 40%. Rheumatology is noteworthy in terms of having a 29% reduction, because in part they just don't have that many high RVU activities. So what's happened here is that all these surgical specialties, cardiothoracic, orthopedic surgery, urology, all of these surgical specialties lost a lot of their surgical volume, lost a lot of their work RVUs, and they were doing more E&M kind of activity. And so that's why you see the greater loss in some of those specialties in terms of the loss of work RVUs. So overall, the intensity of care has changed, and intensity is related to risk. And we've seen not only volume loss, but a drop in intensity of services that have been provided, and using our work RVUs. Rheumatology, hemonc, and OB experienced the least decline. Emergency medicine and gastroenterology experienced the biggest decline in work RVUs. So now let's go into telehealth, because I've had a number of telehealth questions. So this shows you kind of a 7-day rolling average up through the end of last week on telehealth is in red, and office visit activity is in blue. And you can see office visit activity starting to return after April 16th and starting to come back up. And you can see a little bit of a drop there, but starting on April 30th, telehealth starts dropping a little bit. The scale's a little hard to see, but telehealth is starting to come back down. This slide here is a deeper dive on that telehealth drop. And so we peaked at around 900,000 to 1 million telehealth visits a week in the April 23rd to April 30th timeframe. And that's continued to drop. And we've dropped about 30% in terms of our telehealth activity in the United States. The $34,000 question is, where's it going to go in the future? And right now, I don't have a long enough runway to see if that's bottoming out, when it's going to bottom out. My own belief is that, is it going to go back to where it was, as you see in this graph on March 12th? No, it's not going to go all the way back there. Is it going to stay where it is? I think it's probably going to come down some more. And I think it's probably going to end up being probably 50% of what it was at its peak, which is roughly 50% greater than it was before. Would be my forecast, but this is something we're going to be tracking in the data as we go along. Whoops. So let's look at who's using telehealth. And and there are some specialties here. We looked at the telehealth increase by specialty, and you see these multipliers. Hem-onc was up 24 times, pulmonology up 135-fold. Well, that's because there was almost no activity going on whatsoever in those specialties in telehealth. But the thing that's very clear here is that the vast majority of telehealth activity is in family practice, internal med, psych, and peds. That's where all the activity is. Pediatrics had the biggest shift because they had such a low starting point. But in those specialties, that's where we would expect the telehealth to maintain its presence on a go forward. If you look at the use of telehealth encounters, amongst these largely cognitively based specialties, it's very clear that the vast majority of providers were engaging in some form of telehealth. So the yellow slice in here is the subset of providers who were not doing any telehealth whatsoever. And that might be 8 to 10%. So 90% of providers were doing some telehealth, at least one telehealth visit that we see in the data. And then we have providers that have much more telehealth exposure and are doing greater than 20 visits a week. And that's somewhere around 15% in family practice and internal medicine are doing greater than 20 encounters per week. So it's I'm so much surprised by psychiatry that there was roughly 22% of psychiatrists did no telehealth during this first month of the downturn in the month of March. Who's using telehealth? Well, this slide here looks at the age of the provider by years of experience. So 1 to 10 years is providers who have 1 to 10 years of experience, newly minted physicians, whereas greater than 20 are physicians with more than 20 years of experience. And what was a little bit surprising to us is the prevalence in the use of telehealth by the older, more experienced physician group. And that's consistent across all the specialties shown here: family medicine, internal med, psychiatry. The older, more experienced physicians were using more telehealth. Male-female breakdown, pretty similar. A little bit more in terms of male utilization of telehealth, but they were pretty similar by and large. In terms of region of the country, telehealth is most prevalent in the Northeast and the South, and less so in the West. And that's pretty consistent across the specialties. Psychiatry, noteworthy, much more telehealth in psychiatry in the Northeast than there is in the West. But that pattern generally holds: more telehealth in the Northeast and in the South. So as the office-based activity has started to pick up, following April 23rd, we've seen a pullback in telehealth. We're sitting today around a 30% pullback on the amount of telehealth from its peak. People are questioning, is this part of the new normal in healthcare? And I think that, I consume telehealth encounters with my physician, and I love them. And I would pay a price premium to have them over a standard office visit. So I think there's going to be the demand there. What's going to be the question that we're going to have to address is how are insurers going to go about setting reimbursement levels post-COVID around telehealth? And this telehealth payment parity that we're experiencing now certainly has facilitated and put a tailwind behind things. So, that's something we're going to watch. And I don't have a clear crystal ball into knowing what the payer's posture is going to be around telehealth reimbursement levels. But I do think that this has really opened the barn door on telehealth. And it is going to be here primarily and concentrated in your internal medicine, family practice, and peds and psychiatry in those cognitive specialties where it's going to be anchored. A little bit in specialists, but I think that that's likely to be an adjutant for post-surgical follow-up and whatnot, and most of the activity is going to be in the cognitive-based specialists. A final point is that, and I showed this to you all last time we were together, that most of the volume in telehealth is for routine visits for established patients, where there exists already a patient-provider relationship. And this is, once you have that relationship, it's easier to engage in a telehealth kind of encounter. I'll say the same thing as a professor teaching graduate students. It's one thing to have this Zoom facility as an adjutant to a classroom experience. It's another thing for it to be a complete substitute for it, and it's not going to be a good complete substitute. So want to show you a little bit on prescribing. So we have tremendous visibility into prescribing in the country, and the COVID-19 certainly increased anxiety levels in the United States. So we looked at benzodiazepines and opioid agonists. And here we show graphs of the benzos and opioids over time and the prescribing. Some interesting trends. You see on the top panel in red, the peak here associated with new benzodiazepine anti-anxiety drug prescribing that peaked right around the time that we shut the country down. And then you can see everything crater and fall off during the lockdown. Refills, similarly, everybody seemed to stock up. And so on March 15th, we see this big peak in terms of filling and refilling of both opioids and benzos, and then a drop following the shutdown through the rest of the month of March. How about by state? So we're sitting here in Tennessee, and we certainly did not experience what folks did in New York City or in Detroit or Washington State. So we just grabbed a couple of states and looked at prescribing by states, and new prescribing of benzodiazepines, anti-anxiety drugs. And there is, you can see in this peak, everybody peaks a little bit, but we are the blue line here in Tennessee, and we did not rise nearly as much in terms of new benzodiazepine prescriptions as you did in, say, New York State. So in Tennessee, we might have been up about 5%, whereas in New York State, you had a 20% peak in benzo prescribing there. A hypothesis that Rachel had was, did we end up providing more days supply in prescriptions to help get people through this shutdown? Well, and at the outset, we didn't know how long it was going to be. That's the bottom figure. And we really didn't see much change at all in terms of the days supply dispense change. It really didn't move very much at all. So there's the mean total day supply varied only between 14 and 17 days. So there wasn't much change in that. How about people who are on must-have drugs like insulin? Well, insulin users stocked up. So you can see here on March 15th, you see this massive peak in about a 20% rise over baseline in terms of insulin users stocking up on drugs. Is that anomalous? Well, no, not really. If you look at the bottom, you can see dips in fill dates around holidays. But you got your Thanksgiving holiday and you got your Christmas holiday there, but they're short in duration and there's not much of a rebound. So this significant kind of move in insulin here suggests that people might have been thinking this is going to be here for a while. New prescriptions for blood thinners and anticoagulants. Again, you see the same peak and then trough over the month of April, but it seems that they seem to stock up again. Warfarin here on the bottom, other anticoagulants on the top, and whether they're new prescriptions or refills, you do see this kind of peak loading up right before we went into our nation's shutdown. Finally, a similar pattern here for your ACE inhibitors, your antihypertensives, your beta blockers, ACEs, ARBs, calcium channel blockers, things that I use to get by in my daily life. And they all peaked massively here, about a 20% uptick, 15% uptick prior to us heading into the downturn in the month of March. And again, all of this is during the month of March, given our detailed visibility we have in our enterprise data warehouse. And then there is a change in terms of post-lockdown, pre-post lockdown, in terms of refill. So prescribing behavior across the million NPIs and the distribution of how much are new versus refills. And you saw basically a tremendous amount of just refills in the post period. So that's a little bit of what we're seeing right now. I wanted to flag a couple things based on some questions that came in. One question dealt with issues related to seniors and liability. And since I was just showing you some stuff on drugs, I thought I'd take it one step further. And one of the things that we track is prescribing behavior that is consistent with the American Geriatric Society Beers criteria. So these are a set of medications that have been known to be associated with being higher risk in the over 65 population. And so we track this for every physician in the United States. And in general, if you look, the Beers criteria came into existence around 2011. And the percentage of scripts that meet the Beers criteria, that is, they're higher risk in the elderly, has been dropping over time. It's started around 2.4% and has dropped down to about 2% as of last year. So it's dropping in both internal medicine and family practice and emergency medicine, and that's a pretty consistent trend. But what's more interesting here is the variation. And so in general, you've got a 2.18% rate at which these prescriptions are meeting the Beers criteria, saying it's risky in the elderly population. But you do have a set of providers here over on the left who are prescribing as much as 12% of the medications they're prescribing have been identified as being high risk in the elderly population. And so all of this part of the tail here are providers who are prescribing in a way that is higher risk in the elderly population. And then one other thing in terms of risk factors that I thought was interesting is we look at the orthopedic revision rate for all orthopedic surgeons. So you go in and get your total knee or your total hip done, and what share of a physician's patients had to have that surgery redone within 1 year. We actually even look at it whether they did the revision or whether somebody else did the revision. But in general, having a revision is not a very good thing. And so within 1 year. And so this is looking at by age band. And I thought this was interesting, which is why, thank you, Matt, for producing this so I could show this. The younger physicians under 40 have a revision rate that is 75% higher than the older physicians who are over 60. So there's this relationship between revisions and age of a surgeon. In general, we find that revisions and having a high revision rate is a risk factor. And this is showing the distribution of physicians. The majority of physicians are over here, not as many over here in terms of the actual count of providers. But if you unpack that a little bit and you look at the distribution, there are, you've got an average rate of 2.66% revision rate across the country for physicians who did at least 10 joint replacements. And we looked at 2,200 here, and we have a pretty significant population of surgeons, orthopedic surgeons, who have between a 10 and 20% revision rate within the same year on their joint replacements. So that was just another thing that I thought was noteworthy, and Matt was kind enough to share that from Preverity, share that with me today. So That's what we have in terms of our update now, and I'm glad to take some questions here. I'm going to stop sharing this. So our increased volume correlated with lifting of restrictions on elective by governors or state health departments. And so I had a number of questions come in beforehand and regarding my projections around volume return and how individual facilities are handling it. And yes, so the volumes drops were everywhere, even the 7 states that never had the stay at home orders. But the elective surgical scrubbing was nationwide. Volumes are definitely returning in terms of surgical volumes, and I can tell you here in Tennessee, we have providers who are hospital systems who are operating on the weekends and doing whatever they can to fill their beds. As I talk to systems around the country, as of last week, they were back to 80 to 85% of their pre-COVID surgical volumes. They'd come back. And I thought that was actually quite surprising that the surgical volumes had come back that rapidly, in part because I think people have concerns about safety going into the facilities. I think the thing that we're going to have to track here in terms of how quickly the surgical volume returns is we have to be mindful of the fact that roughly 35 million Americans lost their jobs over the last 2 months. Now, we had a wonderful jobs report come out earlier this week, right? It was a huge surprise, and that we had 2.5 million people come back into the workforce, and they were expecting to go the other direction. And so as we look forward, I will be looking a lot at the jobs reports and the employment rate and the return to work, because if you're uninsured, if you have income insecurity, you're much less likely to go back and consume medical care. And that's going to be a revenue challenge for providers, but it's going to be a practical challenge for a lot of individuals who are still unemployed. So I think the volume return numbers I talked about earlier, I'm thinking that we'll probably be back to where we were pre-COVID at the end of July in much of the country. Noteworthy places that won't be there, like Massachusetts looks like it's on a very slow ramp. So we do have some states that are going to be much slower, but all that's going to be tempered by the amount of kind of economic health in our citizenry and the speed with which they go back to getting their jobs is going to be an important impact on that as well. Any other questions? No? Okay, very good. Well, so those are some of our thoughts and what we wanted to share with you today. We're going to continue to do this. I think we might even start talking about canning some of these and just distributing them to all of you, so that you have more ability to watch what we're talking about at a time that makes sense for you, and do some deeper dives into some of the specialties in particular in our next go round. So with that, if we have no more questions, thank you all for joining us, and I'll look forward to updating you with what we see from Preverity in a couple weeks.